the University of Nairobi. Our speaker for the day is none other than Angela Nguko. She is a Deputy Chief Officer, White Ribbon Alliance Global, the founder and executive advisor, White Ribbon Alliance Kenya. And she is many things, but of note is she likes to prioritize women and wants to meet their demands for quality healthcare. She will also focus on the consumers, which are the women and girls, who are the center of decision-making for quality healthcare, and finally loves to highlight the results of Global Women and Girls campaign called the What Women Want. Angela Ngoko, the floor is yours. If you have a presentation, you can mount it up the screen at your convenience. Thank you.
Thank you so much, Dr. Haida. It's really a pleasure to be here. I'm just wondering whether I can be able to share, to be on video. It tells me that this is stopped. So if you can be able to allow me to put on my video, which I'm not sure whether it's working, but we'll see. Let me share my screen. As you rightfully heard, my name is Angela Nguku. I have been in the development space for the last 17 years, let me say that. Can you all see my screen?
Yes, we can. Yes, we can, Angela, we can.
Yeah, I've been in the development space for the last, let me say 16, going to 17 years. And I've worked in many countries. I started my work in South Sudan just immediately after I did my internship in Kenyatta National Hospital after training as a graduate nurse in Nairobi University and leaving in 2004. Let me say that before I go into my presentation and talk about why I'm so passionate about this topic that I was going to share today, let me say that over the years that I have worked in the clinical areas, in training, because I've worked in training, but also as an advocate for women and girls' quality and equity and dignity in health. Let me say that I have learned many things. And what I've learned when I was training, and what I've learned when I was training others, and what I've learned in practice and when I am now advocating, are many things that you will never learn in class. And some of these things you have to learn in process and really apply them as you go along, because in class, we are trained, this is what we ought to do, but the reality and the context where we work in is quite different. So let me say, what pushed me to really be a defender of women and girls' health and rights is what I've seen over the years, and especially when it comes to their voice and agency in defining what care needs to look like. So today, I am really humbled to be here speaking to so many of my colleagues in the space. I'm sure you're working in different spaces. I know some of you have met them, some of you in either in training or in my different circles, but really to share what is it that we need to do to make it easier for women and girls in our country. Dr. Aida, maybe you can tell me, does my screen show like it's a whole screen show, or I can't see it how it looks like, or is it looking like a normal slideshow?
On your screen, it's actually a slit screen where we can see you on half the page, and the other half, we can see your presentation.
The whole of it, or with the normal slideshow?
You can put it on slideshow. It is now on PowerPoint presentation.
Okay, let me just try to do that. Is that fine? Is that better?
Yes, this is excellent. Thank you.
Yeah, so let me start by speaking about White Ribbon Alliance. We are a people-led movement for reproductive health and rights. We've been in this space for the last 20 years, but the Kenyan Alliance came to being sometime back in 2017, when I left what I was doing across different spaces to really just come and speak up for women and girls. Why? Is because after working in this space for quite some time, I thought I'd heard so many stories about women and girls dying in childbirth, dying because they could not access quality care, dying because they could not access a doctor or a midwife or a nurse or someone to attend to them in different areas. Having worked in Africa, Asia, and Latin America, I realized that the contexts were the same and the issues were the same. And one of the key things that was really ailing our space was the fact that you the doctor, you the nurse, you the midwife, you the clinical officer, you the lab technologist, you the person on the supply side, never thinks about the user. What are the perspectives of the user in terms of what kind of care is it that you are giving to the user? Even when you speak to governments, you speak to donors, you speak to different health service providers and the like, Many people will always talk about, let's define quality, but really who is supposed to define quality? Because you can't be the judge and the jury. Yes, I know there's the definition of quality from WHO. There's the definition of quality that you and me were trained on. But there's also the definition of quality that needs to come from the user, that is the mother and the newborn, or the child who's actually visiting that health facility. And that is what White Ribbon Alliance actually has come on board to do, to basically be able to bridge that gap, to bring the voice and agency of the user to the table. And we do this by asking questions around how is your reproductive healthcare like? We listen to what women and girls are telling us, and then we act on their demands. And that is what the What Women Want campaign that I'm about to share to you is also all about. And from there, we ask other people to come on board and also act on what women and girls are saying. Because if we are going really to make a change in the lives of women and girls, then we need to listen to them. They are the users. They are not just passive recipients, but they also should be active members of the care team, so that we can be able to ensure that at the end of the day, we are giving the care that is really needed. So in 2017, let me say, I sat on the People's Advisory Board of the Lancet report that talked about quality of care. It was, I'm sure some of you have read the report that was launched in 2017 that talked about people-centered care in defining what really care looks like. And when I sat in that advisory board, we were supposed to be giving perspectives into what the report said is it the truth? So we went back to the ground to ask different countries, what is it like? What have you had? What is the truth? And it's so interesting that in 2018, immediately after the report launched in September in New York, Kenya launched the Confidential Inquiry into Maternal Deaths report. The report that I'm sure most of you have interacted with, that was the first of its kind in Kenya, and that was done between 2015 and 2016, wanting to understand what really caused the maternal deaths of the women who died in 2014 in this country. And I was shocked when I sat in that meeting. I remember it was at the Intercon, and it spoke about 9 out of 10 women who died in Kenya during that period died as a result of poor quality of care, substandard care that was not meeting the norm of what we are told to take care to give to our clients. It talked about substandard care, but more of that was because women and girls were not seen during the night. There was never a health worker during the night, or even over the weekends. Most of the deaths took place during that time. But more to that, there were so many other issues that were really presented that really depicted the kind of care that we offer as a country. And that got me thinking. And so when White Ribbon Alliance globally, following the Lancet report, but also the Kenya report, we thought we needed to ask, what does quality reproductive healthcare mean from the user perspective? What was really making our mothers either shun our health facilities or die in our health facilities where they're supposed to be actually getting the right care? And we call it the What Women Want campaign, the campaign that really sparked a revolution. The question I have for you today is, are you ready for that revolution? Are you ready to listen to the voices of women and girls, what they told us, and are you ready to change? Are we ready to change as a healthcare team to really ensure that at the end of the day, we are giving care that speaks to the needs that has been articulated by the women and girls who are coming to us? Or are we still going to sit at the back and listen and just give without really caring what the recipient is actually saying? And so the What Women Want campaign was done across 114 countries, and we got 1.2 responses across board. In Kenya, this campaign was in 27 of the 47 counties, and we reached 120,000 responses within a period of 6 to 9 months. That was in 2018 through to sometime in 2019. And this is just a description of the countries. Most of the responses actually came from the very high burden countries in terms of maternal mortality, and it spoke to the need of why investments must actually respond to the needs of women and girls in these countries. Because when you hear commitments, whether there's a sustainable development goals, whether it is the global action plan for healthier lives and well-being, whether it is the Every Woman, Every Newborn campaign, whether it is our own policies in our country, we are speaking about ensuring that we reduce maternal mortality. But what I've seen over time in these countries is that we keep on speaking, we keep to commitments, We keep on talking, but walking the talk remains the pipe dream as a country. So the methodology was really simple. It was a qualitative, purely qualitative ask. It was a qualitative kind of survey. And it was a simple question. What is your one request for quality reproductive maternal health care services? And so this was not like the mainstream surveys, like the quantitative surveys like the current DHS, which is going on. It was a survey that was basically supposed to listen to the lived experiences, the realities of women and girls when they visit our health facilities. And this, we got so many responses across board. We got all sorts of things because we were asking women in all color, in all race, in all, whether they were living in refugee camps, whether they were living disability, whether they were young adolescent girls, whether they were women who are, as long as you are within the reproductive age, this is the survey was all about. We uncoded the responses that came out from this survey, and ultimately we landed on 39 categories, which we actually launched in and put them in a dashboard that I can share with you the link so that you can actually go and interact with the raw responses that have come from women and girls as they speak around their issues. These were the top answers globally, but they are also the top answers in Kenya. So women and girls told us that they want respect and dignified care. Later on, I'll be telling you what does that mean for women and girls. Respect and dignified care is not what you might actually read in books, what that means. Women and girls said they want to be called by name. They said that they want, when they come to a health facility, they want the doctor, the nurse, the clinic officer to be able to smile with them, tell them what you're doing to them, make them feel like they're part of that care. Don't just point to them what they ought to do. Don't refer to them by codes. Don't refer to them by words. Refer to them by name. Let them understand. Give them information. Help them understand what it is that they are going through. They actually told us that, some of them told us that they were so anxious when they go to health facilities that if they can actually find another place to go, not the health facility, they would choose that place to go. The second answer globally was water, sanitation, and hygiene. This is a place that really got me thinking, and I, at the end of the day, ended up actually looking for a donor to support some of the high burden places that I had this request. And this was mainly, for me, what moved me most is women telling us that they go to health facilities and they are told to clean their own beds. That they go to a health facility and they are told to jump onto a bed that another woman, a delivery bed that another woman has just left and just been wiped because it's not running water in a health facility. The thing that really moved me to even act the more is the fact that when we talk to women and girls living disability in 3 counties, I think it was Kisumu, Bungoma, and Makueni, what shocked me is that there are no hospitals in this country. And maybe today, as we interact, you can tell me whether you know of a health facility in this country that has delivery beds that are made for women and girls living disability, especially the physical disability. And so they were demonstrating to us how they go to that facility and they are told, jump on that bed. If you can't, then you have to deliver on the floor. If you can't deliver on the floor, then I don't know what you're coming here to do. You're not supposed to have even gotten pregnant in the first place. Yet we know it is everybody's right to really get pregnant or choose whether to get pregnant or not, whether to have a baby or not. And we tell our women to go to a health facility. There is no health facility that we came across that had the disability-friendly toilets in the maternity where women deliver their babies. It was so shocking to listen to their stories. Some of them were such sad stories that they were crying as they told us the stories because they have to wait in that location, some of them. They have to wait and go actually to look for a place to relieve themselves because they cannot be able to use those health facilities, the toilets in those health facilities. So it was really touching and moving. And we've been able to work with some county governments to actually ensure that they actually put ramps in some of these facilities to be able to put even delivery beds, to procure delivery beds that are convenient for women living with disability, and also toilets that are actually convenient for these women. The third most top answer globally was medicines and supplies. And this was really specific to medicines and supplies that address postpartum bleeding. Because when we talk to women, some of them gave stories of near misses and people, their own kin who have died of maternal death because of postpartum bleeding. You and me know that postpartum bleeding is a leading cause of maternal mortality in this country. There was also a talk around the same. There was an element of transportation to a health facility when a woman is actually bleeding. And the aspect of ambulances and well-functioning ambulances came in at this time. The other top answer globally was kind midwives, increased competent and better supported midwives and nurses. And we later, with our partner, the International Confederation of Midwives, we have actually launched a survey that has been going on. It's actually ending this March, if I'm not wrong, that is actually seeking to understand what do midwives want. Because for the longest time, those people, whether you are a doctor, whether you're a nurse or a midwife or clinical officer working in the labor ward, a lot of the time the blame goes to you. That, oh, you treated us badly. We were not having the right supplies and equipment. But we know very well that in most of these countries, and even in our country, Kenya, a lot of the people who are found in those facilities are the people who are giving that care, either the nurse or the midwife or the doctor or the clinical officer. And mothers will not want to know or understand. They will think that you are the reason why they are not getting what they are getting. And so we went down to ask midwives, what is it that you want to be given to be supported for your role? And the survey results will be soon shared across board. The other thing that we had was that they want increased fully functional and closer health facilities. And that was very big in our country also, especially in the nomadic counties, where they told us that they have to walk such distances. And even in places like our informal settlements, they cannot use those facilities at night because of insecurity. Yes, they are there. They are physically accessible, but they are actually, security-wise, they are not accessible. So there was a lot of ask around those critical areas. And I think today is for us to ask ourselves, what is it that we ought to do? When we had these voices, we did not sit on them. We launched the report in 2019 during the Women Deliver Conference, but in Kenya, we also launched it in 2019 during the CPD conference. And so we have continued working as White Ribbon Alliance globally, but also in our country, to see that whatever we had from women and girls is actually reaching the real players, who is you, me, and others in the policy-making spaces to actually ensure that they start change. Why it was important for us is because as we were speaking to women and girls, what they told us is that they have taken part in so many surveys. And in most of these surveys, they are told to give answers. But at the end of the day, nobody comes back to say this is what we've done with these results. And so as we have seen many more people mobilized, policy changes across board, accountability mechanisms strengthened, resource wins in terms of budgets, health workers hired and promoted in some countries, health facilities updated and upgraded like in our country. The question is, are we going to keep quiet as women and girls keep on telling us their realities in terms of what is it that they want to hear or to be done? Are we going to keep quiet as women and girls keep on demanding for respect and dignity in our health facilities? Let me take you closer home to our country. And even before I do that, the question I want to ask, will you listen? Will you act? Will you be part of the revolution? Because at the end of the day, we want to be part of that revolution. I want to speak a bit about Kenya and talk to you about the key things that we heard from Kenya and why it matters so much to you and me. In Kenya, the topmost request was water, sanitation, and hygiene. And women and girls said that they wanted to feel that there was enough hygiene in the health facility. They wanted to feel that there was the linen was not dirty, that the beds were not dirty, that the sinks were not crowded with food. I'm sure I'm speaking to people or to health workers who, when you go to a health facility, sometimes it's smelling. You find there's food and plates on the sink because there's no running water, and so there's nowhere to wash those dishes. And so women and girls told us that we do not want to see that. We do not want to see dirty toilets. We want to go to a place where when we go, we actually feel like it's a good place. And that's got me thinking, because when I was younger, when I went to a health facility and it was not smelling, I thought there was a problem. Only for me to come to recognize and realize that it's actually a problem. No health facility should be smelling. And let me first applaud KNH because, and I'm not saying this because you are here listening. Recently, I had a patient in KNH and I went to the labor ward deliberately to see how things have been since I last went there. And I was very impressed of the changes that I've seen in that I saw when I was training it, and most recently 2 months ago when I went there. Because actually, you can actually feel that there's so much change that has really been embraced in that health facility, in that maternity. So I really want to applaud that today, because it's something that needs to be recognized, because we need to celebrate the wins that we are making across board. The second topmost request in Kenya was respect and dignity. And that was the place that I had all sorts of issues, including where we do not show our mothers their babies when they deliver, and we tell them that we'll see them 2 days later, a day later. And we do not give them information. And yet we know the anxiety that comes with delivering a baby. Women and girls in Kenya were very particular around lack of information when they are being given care, especially when they go for ANC, when they go for delivery. The doctor, the midwife, the nurse, the clinical officer writes and just gives them the card. Is that really qualified? Is that quality really? Is that really the right care that we were trained that we need to be, both of us need to be part of the care, the client and me, but are we doing the same? I know we are pressed for time. I know we are pressed for so many other clients and other duties, but are we really giving the quality that will make our mothers really understand and be part of that process and be the champions of delivering in our health facilities? And so I want to stop this slide here. I want to go to another slide that will purely talk to the Kenya presentation. But before then, if there's any question, I'll be happy to answer. Back to you, Dr. Moderator.
Thank you very much, Angela, for that amazing and interactive session. We can see so many comments on the chat box. Maybe I could just run through before I go to the Q&A section. So somebody here says they're following, they're listening, and they're watching, they're following, very informative, very good information, crucial information. Someone says they're loving the passion and this is the way change happens. Another says this is the plain truth and it's actually happening in our institutions. Another says together we can do this. Someone is posing a question and says, what do you have for the boy child? I don't know whether you'd want to take that on, as I am looking for more questions, Angela. Another person says, very good information. What is happening on the ground? Change starts with me. Another one says, great presentation. Someone is asking, will CPD points be awarded in this meeting? And the answer is yes. They will be awarded through your different councils. If you're a doctor or a dentist, KMPDC is the one that will do that for you. If you're a pharmacist, then PPB will do that for you. And if you're a nurse, the same happens through your council. So Angela, there was a question about the boy child. Would you want to take that on?
Yes, I would love to do that. And I think that's something I've had across board. And it's something that is always floated across every time, even when we are discussing issues around the gender inequalities that are existing and the biases that have existed across board. But I'm sure women and girls do not live in a vacuum. We are in a community, and the boy child, let me bring it closer home. Let's say it's a man and a woman, and a man has taken their health facility, their wife or their partner to the health facility for delivery. I am sure by us addressing the issues that are impacting the women when they go to deliver, or that partner when they go to deliver, we are actually responding to the needs of that man. We are responding to the needs of their brother, their father, their uncles, and so many more. And so it's not that we are not working with boys and with men. They are part of they're actually our key champions in the work that we do are men and boys, because at the end of the day, we know that they have a key, they hold an important key when it comes to making decisions for where women and girls are going to deliver, because whether we like it or not, we know that we live in a patriarchal society where decision makers are made by men in most of our communities, let's say 80% of their communities. So it's not that we are leaving out the boy child, but remember, at the end of the day, we are addressing women and girls' health issues, pregnancy and childbirth, that is really critical for for all of us and even the work that we do. So we are not leaving out anyone, but we are calling everyone to be a partner, not just a health worker, but everyone else who cares about safe motherhood, because it's everyone's business. Back to you, Dr. Aida.
Thank you very much for that response. Let me see if I can search for some few more comments before we continue. So where were we? All right, so somebody says, thank you very much. I wish to join the change. Another says they wish to be part of that change. Someone else says, these are actually things that we actually don't think about as clinicians, but they make a huge difference in the care, given especially from the patient's perspective. Thank you very much for that comment. Somebody else says, somebody else is asking, could they get us these slides? Could they get this PowerPoint presentation? Maybe you could respond to that later. Another one says, very nice and informative, but what are you as a White Ribbon Alliance doing to archive all this, especially in the public hospitals? Angela?
Thank you so much. I think to start with, yeah, this is shareable. I can share this, send this through to you, but I can also send the links to the Kenyan specific results, the global results, but also what is it that we've been able to do, what else are we doing, including the dashboard, where you'll be able to interact with a very interactive dashboard that has raw data that speaks to different countries, but you can be able to actually pull the Kenyan specific data to actually be able to see what is it that women said in their own words. No, we coded this, we brought this we themed this and put them in categories. But you will, in that dashboard, you'll be able to see the real reality of what women and girls said in their own words, their own spoken words, raw as it is, so that you can be able to understand what it is, the depth of what this is all about. For the participant who has asked about what is it that we are doing, we are doing three things. We are keeping the promise, what we told women and girls that we are going to do. How are we doing that? We are disseminating this information to as many players as possible, not just in the sector, but also in other sectors, because whether you like it or not, maternal health will never be a one sector issue. It's all multi-sectoral. And I say this all the time with reasons. If you listen to what I spoke about, the different aspects that came out of this presentation, or out of this campaign, women and girls told us that they want to be able to access health facilities, easy access, whether it is geographical access, whether it is access in whatever form. And I'll say this and bring in the perspective of other sectors having a role to play in this space. One, the roads networks in our countries are bad. That has nothing to do with a doctor or a nurse or a midwife or a clinical officer coming on board to respond to the needs of women. It is the road sector that needs to take action. And so we are disseminating this resource to everybody, including those in the road and infrastructure sector. When it comes to security, I remember talking to women from Mathare Health, near Mathare Health Center, and they were like, we want to go to the health facility at night, but we are fearing that we will be attacked because the security is an issue in that space. The health facility is there, the healthcare worker is there, but is there security in that place? No. So that becomes again another sector, the security sector that needs to work to ensure that this actually happens. When it comes to issues around nutrition and all that, there's the element of agriculture that we know that standing as a direct impaction on maternal health. If we look at issues around water sanitation, it has nothing to do with the health ministry. It has everything to do with the water ministry and sanitation ministry. And so I can speak to so many of these issues that need to be multi-sectoral. So it is not, we are not just speaking to you as a health workers, we're also speaking to other players, other sectors, including donors and investors, because they need to invest. We're also speaking a lot to the investment around health literacy to the consumer, because we know we live in a world where the consumer or the recipient, the client, is really apathetic. They don't feel like they have a role to play in demanding and standing up. And so we are building their agency and voice to be able to stand up and speak and actually act on this, on what they actually asked for. And I think we're also speaking around the issues around the gendered issues that comes to play when we talk about women and girls. We know that most of the health workers in our countries are midwives, and most of these midwives and nurses are women. And the question that we keep on asking ourselves, and we've had across different countries, is that the fact that it's women being taking care of women in most of our spaces, it could be the reason. It's a gendered issue. It could be a reason why we are not seeing so much investment from wherever space, whether it's government or it is donors investing to ensure that this actually changes. So there's also the gender element that we are bringing to our conversations. because not you and me alone are not going to shape it, to change things. It is many people coming together and acting. And so that is why I left by asking you. We asked, and we'll keep asking as White Ribbon Alliance. We listened and we heard, and we'll keep listening and hearing and bringing it. And we are acting, and because we are sharing with you and doing so many other work with other players to see that actually these changes do occur. The question is, are you going to act yourself? Are you going to listen and act? Because we promise women that we'll talk to as many people as possible to actually listen to them and act. Are you going to? Because you are also represented here in the request that women have made. Back to you.
All right. Thank you very much for those comments. Let me move to the Q&A section. So we have some questions. Okay, somebody says they're really moved by the presentation and they've put up their email address for you to email them the presentation. Thank you for that. Another is asking, is it safe for mothers who have gone through cesarean section to start taking heavy meals at 2 weeks like ugali? Angela?
I'm not sure that is me to answer. I'm the one in the practice now, Tari. Could you please respond to that question?
All right, okay, all right. Thank you for that. So let me just get a few of my gynecologists on the call. I can see there's Dr. Anne Pulei. Dr. Anne Pulei, are you on the call?
Thank you. Yeah,
fantastic.
You can all hear me, Dr. Wanjiku?
Yes, we can hear you, and very good to see you, or rather to hear from you on this platform.
Likewise.
Please answer the question for us. Thank you.
All right, and thank you, Angela. Very nice presentation, and it's a very important aspect in care. It's good that our patients feel respected and cared for as they're presenting. Now, regarding the question about what to eat, 2 weeks after the surgery and a patient has been discharged, they are likely to have good bowel performance, so they should be able to eat what they can manage. Now, ugali is actually a very common meal in Kenya, so that should be totally fine. Githeri should be fine. The things that we usually tell people to not to do is if they have, say, they feel like they're getting constipation, they should make sure that their diet include things that are rich in fiber. And if they feel like they're getting heartburn, they should avoid the foods that can give them heartburn. So basically, it can't be answered generally, but it should be tailored on the patient themselves. So the question that you asked, I don't know whether the participant had a particular patient in mind that had been instructed that, because depending on how the patient was around the time of discharge, the person discharging them may have told them something like that. So I wouldn't want to be very specific, but generally, any mother being discharged 2 weeks after and they're able to eat, they don't have any issue in terms of their gut, they should be able to eat the normal foods that we have in Kenya, and basically just avoid things like that don't have nutritional value, like sodas, processed juices, and so forth. Basically things that can give them heartburn and do not even have nutritional value. So I don't know whether Dr. Wanjiku answered that correctly. If the participant feel like they're adequately answered, they can always text or speak out.
Right, thank you very much, Dr. Pulei. That was an excellent response. I hope that we have been able to answer you, Anna. And if not, then you can type back on the Q&A and I will say it. All right, the next person on the Q&A section is actually giving a comment and saying, thank you very much for taking your time, Angela. Mine is a comment rather than a question. I think it's spectacular for you to take time to also address the public in healthcare decision-making, because alongside bettering the healthcare system, we must also take time to improve health-seeking behavior in the public so that they can seek healthcare in good time. He also goes to say, thank you very much, and please tell us how we can get involved. Another comment by Dr. Dorrell, great presentation. It seems most of the complaints from mothers rotate around positive pregnancy experience, and so preserving respect and autonomy of the mothers is crucial. And then he has a question, does the What Women Want work with the government and public hospitals, as that's where most of the women are taken care of? Angela, back to you.
Thank you. Thank you so much. Let me say that we work with the government, because we know even if we come out with these surveys as much as possible, if we do not have the policymakers, the people who hold the resource key, if we do not work with them, at the end of the day, we are not going to, we are not getting anywhere. It's just going to be another survey, another report really like presented, and life moves on. But at White-Ribbon, we are very big on the feedback loop. We are very big on ensuring that we close that loop, such that when we ask, we want to be able to present. And so we've taken these results to as many counties as possible. And some of them have actually taken this seriously and addressed in their policy documents, in their budgets, in their health facilities. They have changed a few things, and so on and so forth. And so let me say that we work with government, because without government, first, we cannot operate. We cannot tell them, because most of the people, most of our mothers whom we work with live and go to the public health facilities. So we've worked, we bring them even together during town hall meetings. They present themselves these reports to their governments, and they are listened to. At first, of course, there were some government officials or some county government officials, or even in the national government, who are feeling like this is like exposing all the gaps and what are we doing. But when they listened keenly, and when we told them that we want to be critical friends, critical supporters, partners who are actually going to make the priorities that they have for their mothers and for their newborns and their children really come to fruition. They have really embraced the work that we are doing, and we are so glad to be walking the journey with them, working with them as partners to ensure that they are held accountable, and they're also responding, because we know health is a basic human right and it's supposed to be progressively realized by the government to its people. Thank you.
All right, moving on to another question. I think they texted on both the Q&A and the chat. So they say that considering that health is a devolved function and systemic challenges occasioned by this change, what's your opinion on bringing the county leaderships on board without neglecting the role of the national government? And they also go to say that, how do you link this with healthcare system, considering that health is devolved? Angela?
Thank you so much for the question. I think we very much appreciate that health is a default function. At the end of the day, in our country, the policies are made at the national level, but at the end of the day, they need to be, the county governments are also making their own, but or domesticating the national government policies. And the realization that the appreciation that is the reality is how we do our work. We don't just do it at county level, or we don't just do it at the national level. So our work is purely advocacy, accountability, and presenting critical evidence that really should go beyond the numbers, but the stories behind the numbers. So White-Ribbon is so big about the stories behind the numbers, because we'll get the numbers from the service and the like. So we go and sit with stakeholders, not just the government, because there's so much, including the private sector, that has a role to play. And in whether it's the national TWGs, in different spaces where the national government is represented, to really ensure that we take this home. We actually work with them, including the review of their documents, to ensure that they actually pick, and whatever it's getting in is actually from the self-articulated needs and wants of women and girls. At the same time, we also work very closely with the Council of Governors, and also the county themselves, the specific counties where the challenges are, to ensure that the policy environment, the resource environment, the health worker environment is actually addressed at that level. Because when we went through the different requests and the different needs of the different counties that we went into, we realized that they are different. Some could be saying, we want this. Others could be saying, this is our priority. So we are very clear that we don't segment, we don't silo what is already siloed, but we bring these stakeholders together, all of us, different sectors, including the government, who is the leadership in all this, to actually ensure that the issues that we are speaking to are actually responded to. So we are not in siloed, and we are not alone. We are working together in tandem to ensure that the change happens. Yeah.
All right, let's move on to a few comments on this other side. Let me see. So somebody says that none of our events this year have been on the PPB portal, and that is correct. It's because the PPB actually has been delaying on putting that up on your portal, but we've just gotten as a confirmation as of today around 11 o'clock in the morning that this webinar is now up on your portal. So pharmacists, you can now be able to get your CPD points from that end. Somebody else is asking, what about clinical officers? Well, your council is giving us a bit of a challenge. So we are in consultation and negotiation with them. Once we get to an agreement, then we will be able to have these webinars on your portal as well, clinical officers. So sorry about that, but it's really not on us, but we are trying our very best. Somebody else is saying, for any meaningful change, we need to start with the individual herself. Each pregnancy must be planned and wanted. At times, some get pregnancy either unknowingly or deliberately. All right, thank you for that comment. But I would wish to also state that we cannot put blame on any patient, and whether the pregnancy was wanted or not, it is our responsibility as healthcare workers to actually take them through and give them a positive pregnancy experience, regardless of how the conception or around the circumstances in which conception happened. So thank you for that comment. Somebody else is asking, so what about nutritionists? Will CPD points be awarded? We are working on that. Nutritionists, just be on hold. We shall alert you through email when we are up and running on that sector. Another one says there's need for advocacy to women. Someone else says women have supported the girl child. What have men done for the boy child? Angie, would you wanna take on that? So they're saying that women have supported the girl child. So what have men done for the boy child?
Dr. Ida, I think I already answered that question. I know that I said there's a lot of controversy around that. I don't think it's about men supporting the boy child and women supporting the girl's child. I think it's all of us coming together to ensure that the next generation that we are leaving behind really understands their role and their specific roles as it comes to health and women's health and health-seeking behaviors and the like. So I think it's for us to really go back and ask ourselves, where are the gaps? Because support has to be, we support where there's a gap, or we support to ensure that at the end of the day, we come out with a generation that is really understands what are their needs. So I think it's not necessary for a specific sex, whether female or male, to really be able to support one side. I don't think so. I think if we go that direction, we'll become controversial, and we want to be as objective as possible to ensure that at the end of the day, we are living out a generation that can actually stand the test of time, the issues that we are living with, but more to that can be able to thrive and transform the next generations to come. So I think for me, it's about what is the issue and how can we best address it together, not in siloed approaches. There's also the element around what are we doing to the mothers. I think I spoke to the issue about literacy and information. And this came out a lot from younger mothers and younger girls around information, not just around maternal health issues, but also around their menstrual health, their changing bodies, but also their transition to being mothers and the like, and the health-seeking behavior and the like. So I really remember and I treasure the trainings we used to give to mothers when they come to health facilities. But I understand from the What Midwives Want campaign that is almost reducing. It's reducing because we have lesser and lesser health workers. So the question is, how do we ensure that there is enough investments such that our mothers can actually get the literacy they need to be able to make decisions that are in support of the work that we are doing, so that they can be able to eat well, eat healthy, come to the clinic on time and the like. At the same time, KNH-UoN Alliance has launched the self-care, which is basically the root of healthcare, where we are going back to the basics, where we are educating and advocating for embracing the basics of self-care, where everything doesn't have to take place in a health facility. It can start at home. It can be more like going back to the primary healthcare element. How do we go back there? How do we ensure that that can actually take place? So I think there's a lot that we need to do, and you and me can still keep on doing this and pushing and joining the movement to be part of that revolution. Back to you.
Absolutely. I also wanted to just weigh in on that and say that it is not a battle between genders. It's actually a collaboration. We are not targeting gender equality per se. We are targeting gender equity. So that means that we want everything to be equitable, not necessarily equal. Because if we start to say we are fighting for equality, so we will definitely lose the battle. So thank you very much for that, Angie. Let me see whether there are more comments on either side. Let me see what somebody's saying here. All right, so we have somebody saying that's a real truth. Thank you very much for this information. Somebody else says, very true indeed. Efficient maternal care delivery can be achieved only by multi-sectoral approach. WHO developed the 6 building blocks of an efficient healthcare system, and it includes service delivery, health workforce, health information, ability to locally produce medical consumables, adequate health financing, and good leadership and governance. Thank you very much for that comment. Somebody else is saying, thank you for your presentation. They wanted to find out if we can introduce joint endocrine and gynecology clinics for mothers with GDM and type 1 and type 2 DM and other endocrine conditions in pregnancy. Well, I don't know what you mean. Do you mean in the setup of KNH or just generally all over public hospitals? Maybe if you're still on the call, Ellen Jackie, you could just write that so that we know how you'd want us to answer that question. Moving on, somebody else says, very informative, thank you, and keep up the good work. So those are more accolades to your heart, Angela. Somebody else says, thank you for the smart presentation, especially on maternity care. Somebody else says that we see most mothers with headache as a side effect of cesarean section are advised to take Coca-Cola soda. Is this the right approach? Or is there any other way that we can approach this? So I'm gonna shoot that question to Dr. Samuel Kagema. He is one of the freshest gynecologists we have just released from the University of Nairobi. So Dr. Samuel Kagema, if you're on the call, please take up that question, please. Dr. Samuel Kagema. All right, he seems not to be on the call. All right, let me get you somebody else who can answer that question. And as I do so, I can be reading more comments. Other comments are still more accolades. Thank you for the presentation. Excellent presentation, informative. Somebody else says informative presentation, excellent presentation. They're still asking if you could share the PowerPoint presentation, Angela. So I think we're going to do that once we're done with this. There's somebody else who says, this is a very clear and precise presentation, and they have a question. Is it normal for a mother to experience bleeding during pregnancy, and how often can it last? So I think the questions you are asking are more towards healthcare workers, that is obstetrician, gynecologists, and not particularly to our speaker of the day. But anyway, we are going to try and see who's on the call that can respond to them. Meantime, let me come back to the, yes.
Dr. Njiko, I'm back. This is Dr. Pulei.
Excellent. Thank you very much for coming back. We have a few questions that need to be addressed by you. Let me just get them. Let me just go, just give me 1 minute to get them. All right, so the first question was, do you think that it would be important to link endocrine conditions with the GOPC clinics?
Well,
Dr.
yes, now I briefly saw that question. I think it's related to women who have gestational diabetes and whether it would be nice to like follow them up with an endocrinologist in the same sitting and a nutritionist in the same sitting. And I feel like if the person asking that is asking from the the point of admin and changing that, that would be ideal, because women with such complications in pregnancy should be managed with a bigger team, not necessarily by one person. So it shouldn't just be a gynecologist or a medical officer or a clinical officer. If that's the one that's available, that's a patient who should be handled in a multidisciplinary way. So having them attend the clinic at one point has been shown in many things to increase compliance, as opposed to coming today to see a nutritionist, tomorrow to see a gynecologist, the day after tomorrow to see an endocrinologist. The best would be having them all, in fact, even in the same room at once. But since that is not feasible, then having integration in terms of the endocrinology clinic here, then the obstetric clinic here, and then the nutritionist in the other end, that would be perfect. So if you're asking if that's okay, that should be fine if it can be done in your setting. Now, I've seen a question about soda and, like someone was taking Coke about spinal headache. Now, briefly, spinal headache happens for people who have had a lumbar puncture or a spinal anesthesia. And why it happens is just because of that drop in CSF volume. That's what is thought to be the problem. And the logic behind giving soda, Coke in particular, which personally I don't prescribe it, but I'm just saying the logic behind the person who gives it would be to give caffeine. So any drink that has caffeine should be fine. The other option is using drugs that already have caffeine, one of which would be something like Pinstop or Betapine. Those are drugs that have paracetamol. They also have a bit of codeine and caffeine. So anything with caffeine would be useful for the woman. Mild cases of spinal headache. Telling them to rest is also helpful because they experience that headache when they move, when they stand, that's when the headache becomes worse. And generally speaking, it wouldn't be nice to tell someone, say, who has gestational diabetes to take Coke if they have a headache. So for that patient, you may tell them to take black coffee, or you can give them Betapine because it already has a caffeine. I don't know whether there's any other question, Dr. Andriko, related to me directly. And
yes, there's more. There's more, yeah. But you can go on.
Oh yeah, because we are talking nutrition, I've seen a couple of questions on nutrition. Generally speaking, nutrition is all-rounded, that everyone, pregnant, breastfeeding, a child, ourselves, we're all supposed to be doing balanced diet. That's the message. Unless someone has got a specific condition, people with diabetes or people who have peptic ulcer disease and some things affect them. So the general message for anyone would be a balanced diet. So preferably whole grain carbohydrates, a very nice protein, and fruits and vegetables. That should be daily. And you can always ask this by asking someone what they ate like last night. What did you eat last night? What did you eat in the morning? So that you know whether they're eating balanced diet. Include fats, which are found in fruits like avocado or even nuts, and some seeds like sunflower seeds and so forth. And they should include water intake. So generally, that's a message that every patient should be given. So I don't know whether there are other questions on nutrition in the chat, but anyway, Dr. Andriko can let me know of any other that I can answer.
All right, there's another question. Is it normal for a mother to experience bleeding during pregnancy? And how often can it last? I think, well, we could just say like generally, just give a comment, please.
Yeah, now great question. Again, it sounds like a specific question, but bleeding in pregnancy is a problem. Any person experiencing bleeding in pregnancy, that's not supposed to be the norm. But it doesn't mean that it cannot be handled. So a woman who experienced bleeding in the first trimester should be followed up by a gynecologist. If that's not available, a medical officer should be fine, and they can consult a gynecologist. It's okay to consult even across counties. Anyone who is a gynecologist should be told about such a patient. So in the first trimester bleeding, there are things that we use. We must assess what is the cause of bleeding. Is it something related to placentation? Is it something related to possibility of a miscarriage? So we group that. So women who have, say, a threatened miscarriage will end up being given something like a progesterone to support that. Or if they have a subchorionic hemorrhage that is even showing and they are bleeding, they should be treated. Is it an infection? Is it trauma? So it should be handled like that. Now, when you're moving to the second or third trimester, bleeding of that is either related to the baby or the mother. So the mother, it would be something to do with placentation, placenta previa, or abruptio placenta. And do they have, does this woman have, say, high blood pressure? Because that's the commonest cause of abruptio placenta. And if it's previa, it's handled differently. They're supposed not to engage in coitus. They're never supposed to have digital examination. They shouldn't be lifting like heavy weights. They can do exercises tolerated, very minimal, walking and stuff. And delivery is different. So that's, I'm talking about previa. And then if it's an abruptio, again, should be followed up, whatever they have. If it's very, dependent on how bad it is. Some may warrant immediate delivery, depending on how the maternal is, maternal vitals, and also the fetal vitals and the gestation. So I'm trying to answer about very wide topics that could be potentially dangerous. And that's the reason I'm very general. So, but just to maybe reiterate on what the person was trying to ask, I'm assuming it's someone who had been bleeding from early pregnancy, and that's a person probably who was given some progesterone. Usually such patients, by the time they reach the second trimester, third trimester, they stop bleeding, unless there's an issue in placentation like previa. And if they do, they have to be advised to be near the hospital and, avoid heavy activities and sex and so forth. Now, I'm seeing a question about salbutamol as a tocolytic and for how long. Again, these are very big topics. Tocolytics are grouped, and the commonest used would be something like nifedipine, and we also use terbutaline. Some people use salbutamol if it's affordable. And the purpose of a tocolytic is just to give that 48 hours of fetal lung maturity. That's the main purpose of tocolytic. If they're given for preterm labor, you usually just stop it so that, give it so that the labor can stop with the contractions, so that you can give fetal lung maturity time, and then now the decision to deliver. Now, heavy bleeding, again, in pregnancy is an emergency. A patient shouldn't be on their own. And if it's in a situation where you're very far off and you do not have any help, and you don't know what to do, you can call and plan the patient for referral. Because someone with previous shouldn't be living like 3 hours away from a hospital. Because if they bleed, say at 34 weeks, they could bleed on their transit to hospital. So it should be someone who can even be housed. There are hospitals that have hostels around, or you can even admit, like a previous patient, logically speaking, living in a place where there is no transport and is very far from a hospital, can be admitted even from 20 weeks. They should be in hospital, so that at least you save that life. In places like Nairobi, we can afford to have them go home. And if they live in Nairobi in a place that's far, they should be admitted as well. Like, if say they live in a place that's outskirts of Nairobi and reaching a hospital is far, it's better to be in a hospital setting. So I'm hoping I'm answering those questions that have been put. Dr. Njiko, any other?
Actually, I think the questions that are being asked are very wide obstetric questions, or rather topics, and we may not be able to do it justice if we just give short answers. So I may have to not read all of them, but thank you very much, Dr. Pulei, for your responses. Let me be on the hunt for any more questions, maybe pertaining safe maternal care. So let me see what people are saying. So somebody's saying there is need for proper partnership to achieve safe maternal care, such as ministries of transport, agriculture, interior security, etc. So that's a good comment. Thank you for that comment. Somebody else says, excellent presentation, and they would want the link sent, or rather the PowerPoint presentation sent to them. Somebody is saying, somebody's asking, do you empower women by teaching fertility education and total wellness goals? I think maybe now that question could be taken up. I don't understand. What do you mean by do you empower women by teaching fertility education? Actually, the answer is yes. Yes, we should be able to teach our patients and our women everywhere, in churches, in mosques, in the markets, when they come to the clinics. We should be able to empower women by giving them the information they need in matters family planning. So I've been able to handle that. Another one says, excellent presentation. Somebody else says, you have a broad multi-sectoral sectoral approach to identify and manage, and I applaud you for this wide vision and work involved. Those are additional accolades to you, Angela. Somebody else says, I also think we need to integrate mental health assessment tools during antenatal care to ensure postpartum depression is addressed early. So that's a comment. Somebody else says, good presentation in your campaigns. And then the question is, do you include private sectors or do you only consider the public hospitals? Angela, we are back to you now.
Thank you so much, Dr. Ida. I think what I said during one of the times I was speaking is that mothers go to whichever health facility. They actually don't differentiate sometimes based on where they live, whether it is a public facilities, whether it's a faith-based, whether it's a charity facility, or even a private facility. So at the end of the day, this message is for all health facilities, is for all health workers, where they are talking about respect and dignity. They did not say that we get it better here. And this was not just done for women and girls living in the usual geographic marginalized areas. We spoke to women even living in high-end areas. And what we heard from them is that we are not getting it right. So at the end of the day, I think it's for all of us, whether in whichever place, and we are preaching quality, dignity, equity across board. It doesn't matter whether it's a public facility or not. So I would say that it's everywhere, and everybody is invited to be a partner in this because, again, as I said, it's everyone's business.
All right, thank you. I also hope that our host KNH research team is noting the many topics that are coming out of the questions, yeah? So we actually would need to discuss about antenatal hemorrhage, antepartum hemorrhage, that's APH, the question came out of there. We would also need to discuss about nutrition in pregnancy. Somebody else is asking about gastritis in pregnancy. Those are whole topics that can take an hour each. So if the KNH research team is noting those down and can host them at a later date, that would be excellent. Somebody else says, somebody else is asking about anti-malarial drugs in the first trimester. Those are just more topics. That means we just need to do a webinar on malaria and pregnancy. Let me go back to the Q&A. Here we have a few more. I like this question. Somebody asks, what do women above 40 years want? Angela, we're back to you.
I'm not sure whether that question was asked because I'm over 40, but I recently turned 40 and I'm enjoying it. But I think for me, it's not about what women of at this age want. I think we spoke to different cohorts, and I'll tell you that the younger women that we spoke to, and I'm speaking in context of this campaign and the survey that we did, the younger women want, they want more information. They want to be directed to what they ought to, because they actually told us they feel confused. They no longer feel like when they go to a health facility, they are getting anything besides medication and papers written and nothing is explained to them, at least a majority of them. So they say they want information. The same thing, the ones who are 25 and above all the way to 45, they actually are the ones that are very grounded and they want respect and dignity. They want to find a health facility that is receptive to their needs, not the other way around. So they are very clear on what they want. They are very clear on what they are finding, and they are very clear and ready to speak up. So I think it's about us realizing that there are many needs and wants of women who are within the reproductive age and who are visiting our health facilities. The question is, how are we going to respond to their needs and wants at the end of the day and ensure that they can come back again, but no more to that we actually have better maternal and newborn health outcomes at the end of the day, because I believe that is what you and me want at the end of the day. Thank you.
All right, thank you very much on that elaborative response on the different age groups and what they actually want. We are now coming to the tail end of this presentation. Thank you very much for your many questions and comments. Just a quick note is the presentation has been uploaded on the KNH website. Number 2 is for doctors and dentists. Please get these CPD points via the KMPDC website. They will be up and running in 2 weeks. Same applies to the PPB portal. And as for the clinical officers, we are still in negotiation with that. So we are not yet on the clinical officers council. And then you can see, as is being featured on the screen, the Nursing Council CPD token is there on your screen. As pertains nutritionists and lab technicians, we are yet to get to your platforms. We are working on that as well. Questions are, how does one become a part of the White Ribbon Alliance? Angela, and then you could also give your closing remarks.
Thank you so much. White Ribbon Alliance, as I said, is a movement. And being a movement, anyone who has an interest to see that, to keep asking, listening, and acting on women and girls' self-articulated demands is welcome to be part of us. We work across the different counties across board. You can either visit our website and learn more about us, but also visit us. We are on, in Nairobi, we're in Kilimani Wood Avenue, but we're in the process of actually going into a membership recruitment drive for those who want to be part of this movement. So feel free to reach out. I'm sure the team in KNH has our contacts. Those who are interested, they can share the contact with us and we can see how they can become part of the movement. And basically push this agenda, because it's a movement's agenda is not an agenda that is anchored on an organization. It's an agenda for everybody. So you push the women's agenda, their needs agenda, the what women want agenda. So I think it's good that we become part of that, those ambassadors, but also the actors, because we are also decision makers in our different spaces. I think my parting shot is really fast to say thank you so much for taking your time to listen in and just engage. I think it was one of my engaging sessions where you see people asking questions and the like. But more to that is actually to leave you with a parting shot, because at the end of the day, you are a health worker, or wherever you're working, or whether you're a student or not, you are really seeking out to see your clients coming out from you happy, healthy, and the like. But the question is, are you ready yourself? And I think this is for you to be left thinking as you go along. Are you ready to listen? Are you ready to give a platform for your client to really also contribute to the care that you are giving at the end of the day? And I believe if we are, both of us, all of us ready to do that, then we are really like joining the movement, listening, asking, listening, and acting. And we're actually ready for the revolution, that of listening to the needs and responding to the needs of women and girls. So thank you so much for really taking your time, and I'm happy to come back on board and just be part of it. Thank you so much.
All right, a very big thank you to you as well for taking time off your busy schedule to actually bring to us this afternoon webinar. Just to remind everybody that tomorrow, same time, same place, we will be having our fistula guru, Dr. Weston Kisa, and myself on all matters obstetric fistula. Thank you very much to all the 1,000 attendees and participants. I am overwhelmed, and this was absolutely amazing. Thank you very much for joining us, and until tomorrow, keep safe and remember to always give your patients a positive pregnancy experience. Until tomorrow, my name is Dr. Ida Wanjiko. I have been your moderator. Such a pleasure to have been with you all. And until next time, I say good afternoon to everybody. You can leave at your own pleasure.
Thank you so much. Good afternoon.